Right. Well, good evening, everyone. I would like to welcome you tonight and thank you for coming along to this European School of Urology webinar. And this is an update on testicular cancer guidelines. We'd like to discuss a number of topics with a number of my colleagues from the Testis Guidelines panel. The 3 points that we're going to discuss are a slightly eclectic group of topics covering various aspects of testicular cancer. And we'll begin with Anna Patrikidou from France, who will talk about recommended chemotherapy protocols, including de-escalation concepts in stage 2 seminoma. Changing tack, Professor Axel Heidenreich from Germany will then discuss thromboprophylaxis and risk factors for thromboembolic events. And to conclude the session, Boormans from the Netherlands will talk about new staging and prognostic symptom scores that are evolving and will be shortly incorporated in new guidelines. I've got no conflicts of interest to declare. And just as a brief overview, the Testicular Cancer Guidelines is an annual publication that's readily accessible on the web, and it's annually updated based on incorporation of new literature, which is then considered by the panel. Changes we made in the ones published earlier this year involved a revision of the main text without an extensive scope search, and also an expansion of the use of appendices. And within these appendices, which are standalone chapters on the web, but not the printed version, we have those dealing with quality of life, long-term toxicities of care, a tabulated outline of chemotherapeutic protocols, which Anna was seminal in leading that event, and also prevention of thromboprophylaxis during chemotherapy. Next year, our plans are to undertake a full scope search, which embraces 2 full years of new publications, which are then analysed by the panel, discussed, and incorporated into guidelines as the evidence evolves. We also wish to continue to expand the content and scope of the guidelines, and this is facilitated by the use of appendices. So they're web-based, and so constraint of space is not the same issue that we have with the printed version. And emphasis points we plan would encompass hypergonadism, a more detailed analysis of different imaging modalities. In the current guidelines, we more just look at the sequence of imaging, prognostic scoring, and also care pathways on diagnosis, treatment of both stage 1 and also metastatic disease. And of these initiatives over the past year and the coming year, we're going to discuss 3 of the topics which I've highlighted here. And I'll deal with them in the order they're listed here, and would like to introduce my colleague Anna Patrikidou, who's a medical oncologist who's been involved with the guidelines, and as I mentioned, largely oversaw and wrote the chemotherapy supplement, which is now in tabular form, which we hope will be of assistance to you. So, Anna, with that, would you like to take over and walk us through chemotherapy?
Yes, of course. Thank you, David. Let me try and share my screen. I should be this one. Can you all see my screen? Is that okay for everyone? So good evening to everyone from me as well. Anna Patrikidou. I am a consultant medical oncologist at the Gender Urinary Oncology team at Gustave Roussy, as well as the Early Drug Development and Innovation Department. Thank you, David, for reminding me that I only have 15 minutes to discuss chemotherapy, and not only, including de-escalation strategies in stage 2 seminoma. I might overstep a little bit, hopefully not. These are my disclosures. Let's start by talking numbers. The incidence of germ cell tumor in general is rising. We have double the incidence now than it was in the 70s. It is 10 times more common in males of Northern European ancestry and 5 times more common in all white race males compared to others. In the United States, between 1988 and 2001, the incidence has increased by 100%, it doubled. Of that, diagnosis of seminoma increased by 124%, and that of non-seminoma by 64%. Still, metastatic seminomatous disease remains rare. This is a very complicated algorithm that I'll try to go through with you. So basically, the majority of seminomas are diagnosed as stage 1. There's only a 10% of semis that are diagnosed de novo stage 2. Approximately half of stage 1 undergo active surveillance. Of these, 12% will recur, which gives us a 6% of seminomas recurring within the total number. Most recurrences occur in the retroperitoneal nodes. So that's a 5% recurrent stage 2 plus 10% de novo. That's 15% of stage 2 seminomas in the total number of seminomas. Now, treatment is directed by clinical stage and prognostic group, the IGCCG risk group, which, as you can see on the right, for seminoma is essentially being dictated by the presence or absence of non-pulmonary visceral mass. This is the incidence in the small orange tags and survival outcomes per prognostic groups, much improved at the update of the classification, with the better, essentially, chemotherapy regimens that we have in the recent decades. And this is the incidence per disease stage, as we can see, a highly curable disease, which we should maintain as such, and if possible, cure everyone. So what do the guidelines tell us? How should we treat stage 2 seminoma? I have cited here all major 3, not just ours, and my aim is to indicate the consistencies, but also the heterogeneities. For stage 2C, there's a clear uniformity. All guidelines say treat as per stage 3, which means chemotherapy. For stages 2A and B, however, there is less uniformity. There are, in fact, 2 treatment modalities, radiotherapy and chemotherapy, and there is a variety of options of what the preferred modality is across guidelines. When there is a heterogeneity of opinions, it means that the evidence we have is not absolutely strong. And this means, or ought to mean, that the field is moving, that there is research ongoing specifically to clarify the field. The truth for chemotherapy versus radiotherapy in stage 2A and 2B seminoma is that we have no randomized prospective head-to-head trial. Both options are used in the practice with regional variations, at least across Europe, and we'll see that in a second. Radiotherapy was gradually replaced by chemotherapy as the preferred treatment modality over the last decades, especially for stage 2B, owing to better relapse rates for chemotherapy, especially for bulkier disease, and fears of a long-term toxicity of radiotherapy. We have one systematic review from 2015 that indicated that radiotherapy and chemotherapy are equally effective in 2A and 2B seminoma, but we have a trend in favor of chemotherapy in 2B because of fewer side effects and lower relapse rates. And this is even more pertinent if the analysis is limited, as you can see on the right, to the patients that were treated as per the actual current standard of care protocols, respectively, for chemotherapy and radiotherapy. There is one thing that we should not forget: marker negative stage 2A disease should be followed with repeat imaging, and treatment should not be initiated unless metastatic disease is unequivocal. And this is based on biopsy, increasing nodal size or number, or a subsequent marker rise. This is a slide that Alex Papachristophilou from Switzerland lent me. It shows the patterns of curves to the UK on the left, and Switzerland, Germany, Austria to the right. And we can very clearly see that essentially treatment decisions are split for stage 2 in regard with chemotherapy and radiotherapy as preferred treatment modality overall, with a preference for radiotherapy in stage 2A in the data that we have in the UK. I do not have similar graphs for France, but I can tell you that globally, we follow up stage 2A until stage progression or positive markers, and we mostly give chemotherapy for stage 2B seminoma. So what is this chemotherapy that we use for stage 2? All stage 2 seminomas are by definition good risk. Therefore, chemotherapy should be either 3-BEP or 4 EPs, etoposide platinum versus etoposide cisplatin versus etoposide cisplatin bleomycin, as our guidelines say. We don't have a pure head-to-head here either, but we have the French GETUG S99 trial that included patients with clear indication for chemo, and that was stage 2B upwards or positive markers. The good prognosis in this trial were treated with 4 EPs, and the intermediate prognosis with 4 VIPs. The trial showed that 4 EPs can cure the majority of good prognosis tumors, 99% overall survival at 3 years, 93% at 5 years, comparable with what is reported for 3-BEPs, avoiding at the same time bleomycin toxicity. And what is the standard regimen for radiotherapy, which, as we said, is preferred for non-bulky stage 2 disease? This is applied to the so-called dogleg or hockey stick field, the para-aortic and ipsilateral pelvic nodes. A dose of 30 grays used for stage 2A, 36 gray for stage 2B, our guidelines say. And this in color is what the PTV, the planning target volume, looks like in practice for this radiotherapy. The larger the PTV, the higher the risk for all treatment-related toxicities, including secondary malignancies, and this is something to keep in mind. And these are the standard outcomes for radiotherapy: good PFS in stage 2A, but over 10% distant relapses in 2B. And distant relapses mean need for higher burden chemo. As we said, most experts recommend chemotherapy over radiotherapy for 2B and 2C disease because of high relapse rates after radiation and a high risk of secondary malignancies. So chemotherapy was most frequently used in stage 2 overall. And this brings into light the very real problem of long-term chemotherapy toxicity and survivorship, quality of life and health, particularly secondary leukemias and cardiovascular disease. We were worried in the past regarding radiotherapy, and now that the standard of care has shifted towards chemo, we're also worried about chemo's life side effects. So de-escalation strategies arise, aiming to decrease this toxicity and the burden of treatment, all the while maintaining the high cure rates we have achieved for this disease, and eventually individualizing treatment better. How do we de-escalate? We can decrease chemotherapy doses, we can decrease radiotherapy doses, use chemo-radiotherapy combinations, or increase the use of surgery, all the while preserving oncological outcomes and cure rates. Examples of such de-escalation strategies: I will start with a French semi-TEP trial, de-escalating chemotherapy based on an interim PET-FDG, a phase 2 trial in good prognosis, stages 2B to 3. The concept was simple: de-escalation based on complete metabolic response. The standard in France is 4 EPs. All patients received 2 EPs, then an early FDG PET. If PET was positive, the course was completed with another 2 EPs. If PET entirely negative, patients received 1 single cycle of carboplatin AUC7. Before I give you the results, here's the background to this strategy. In post-chemotherapy residual masses in the SEMTEP trial, PET-FDG has 100% specificity. That means that when there is no tumor, the PET will always be negative. And it had 96% negative predictive value. So out of 100 negative PETs, only 4 will be false negatives. In the SEMPECON trial, the retrospective validation of the SEMTEP results in approximately double the number of patients, 90% specificity, 95% NPV. As for the value of the interim PET, we have some data from this observational retrospective study on 70 patients, stage 2 and 3 semis, that used the FDG PET after 2 cycles of chemo. That was mostly BEP. And this is how they were repartitioned in terms of stage and PET positivity. These are the all-stage results, and these are the results at the different stages. overall significant predictive ability in terms of relapse-free survival across stages. Going back to semitep, when this strategy of interim PET was applied prospectively to guide a de-escalation strategy in a randomized fashion, this was the outcome. A very interesting de-escalation result, certainly not inferior to the full 4 EPs, and certainly less toxic, notably for the neuropathy and ototoxicity of cisplatin. Remember, this is the second aim of a de-escalation strategy, to decrease toxicity. But it's not ready yet for prime time. We need longer follow-up to ensure no risk of later relapse in the de-escalated group. We need a better definition of metabolic positivity, and we need larger prospective trials, ideally international trials, to confirm these results. But these results are promising enough to merit a mention in our next year's guideline. Another way to de-escalate is to combine two de-intensified treatment modalities. This is the example of the SAC-0110 trial that aimed to address both local and distance disease control, all the while avoiding the toxicity of large volume radiotherapy and polychemotherapy. So, trial in stage 2A or stage 2B seminoma, de novo recurring, one induction cycle of carboplatin AUC7, followed by involved node field radiation only. The dose were according to stage. The escalation for chemotherapy is obvious. We go from 3 BEPs or 4 EPs to 1 cycle of carboplatin only. For the de-escalation in the radiotherapy, do you remember the PTV of the hockey stick classical irradiation? This is the one on the top. The radiation volume in SAC-0110 was decreased by 75%, expected to translate into enormous proportional decrease of the secondary malignancy risk. 116 patients, the largest stage 2AB seminoma trial to date, to my knowledge. And here are the reported outcomes. At least comparable with the 2 monotherapy standard of cares, although this is more true for the stage 2A than the 2B. A very good safety profile, no toxicity at all for more than half of the patients. And grade 3/4 toxicity was limited to less than 10% of the patients. It was mainly transient cytopenias. So a very convenient treatment with a low toxicity burden for patients who are very frequently in the peak of their professional life. The criticism, this is a non-randomized trial. And importantly, strictly speaking, the trial did not meet its primary endpoint. The lower limit of the confidence interval was 88.5, whilst it needed 90 as per its statistical design. But a very interesting approach, and it will be mentioned, although not recommended, in the next year's guideline. In my opinion, the future is in intelligently designing combination de-escalation strategies. And this is how the Swiss colleagues are following up on their SAC-0110 results. They're escalating chemotherapy in stage 2B by using 1 cycle of EP to counter distant failures, the main issue that they saw before. This is escalating compared to carboplatin AUC7. Overall, it is still de-escalating compared to the full 3 BEPs or 4 EPs. And they reduced radiotherapy dose by about 20% in both cohorts, since no local recurrences were seen. And they're including a translational research component on measurement of microRNA 371. And this is the French approach, EDEN. This is a phase 2 study in low volume stage 2 disease, less than 3 centimeters, largest diameter, utilizing an early PET, even earlier than semitep, after 1 cycle, to guide randomization between adding 1 cycle of carboplatin AUC7 or 20 to 30 gray radiotherapy, depending on nodal size. And it also integrates microRNA 371 biomarker evaluation. Now, finally, we also tried to de-escalate using surgery only. This is an attractive approach because it avoids radiotherapy and chemotherapy-related toxicity. No? Yes, when it is sufficient on its own, and it's not always. This is a recap of the so far published trials from a slide presented at the last EAU Congress by Martin Albertson. in the best of closing session. Safety is certainly overall good. The rate of adverse events in skilled hands is low. I emphasize skilled hands. These trials were carried out in high volume RPLND centers. Nevertheless, we can certainly identify shortcomings. In terms of design, rather heterogeneous populations. Most of these trials looked at stage 2A. Some also addressed rather limited stage 2B. Some looked exclusively at marker-negative disease. Others were more agnostic. And one would say that completely excluding a marker-positive disease from systemic treatment is rather risky. Some of the trials actually included adjuvant chemotherapy, which raises the question of the true purpose of RPLND. Is it to avoid any chemotherapy at all costs, or is it to deliver a local treatment in skilled hands, perhaps less toxic than radiotherapy together with chemotherapy? But most importantly, outcomes issues. The follow-up is variable, but most importantly, short. The SEMS trial, looking at less than 3 centimeter disease with an actual median size of 1.6 centimeters, reported on a 2 years PFS and had a 22% relapse rate. This is more than double than reported for chemotherapy or radiotherapy, which is 10%. And it does not include even the patients that would relapse after year 2, in the 3rd year or later. And PRIME test reported an even worse relapse rate, 30%. And it did not meet its primary endpoint. So the question begs, how much relapse rate ought we accept from a surgery-only approach? All of the above reasons make, of course, direct comparisons of this surgical series to chemotherapy rather challenging. Therefore, RPLND cannot as yet be recommended as standard treatment. It is mentioned in our guidelines this year, and there will be a mention also next year, but it is not recommended for routine use. Overall, and to finish, the next generation of surgical trials need to be more intelligent. We need to use predictive factors to select patients for this surgery-only approach, and this could be nodal size, LDH, or even microRNA expression, or to focus on safely postponing salvage therapies, and safely meaning that either the patients that we choose to operate upon will not relapse, or if they do so, the oncological outcome would not be compromised because they would still need to be able to use the full dose chemotherapy for metastatic disease as indicated. So let's all stay tuned and keep a good contact amongst each other as specialists of different trades. We need to work together in order to optimize the care and life of these men with a very curable cancer, and for the care of whom no error ought to be allowed, really. Thank you.
Thank you very much, Anna. If you have questions, there is a web chat that people can pose them on. None have appeared, but I'd like to just put a couple of different clinical scenarios to you and just see how you would see as preferred treatment. Remembering that seminoma can affect quite a diverse range of patients, perhaps more so than non-seminoma. So the 3 scenarios will be a 32-year-old man who's otherwise fit and healthy, a 45-year-old man who's been a moderate smoker but no significant disease, and finally a 64-year-old man. They all have 2A disease, and their lymph node has been growing after an initial equivocal node on a repeat scan has increased in size, and so there's been progression of disease. So in those 3 scenarios, what would you recommend if these were patients you're seeing in clinic?
Right. So first of all, over what time have the nodes been growing? Do they still remain 2A? And what are the markers doing?
They were 12, 15 millimeters initially and went up to 25 to 30 millimeters in maximum diameter. So that's
2B now.
Yeah. So they're moving along.
And initially the markers were negative.
Markers always been negative, no LDH or other tumor markers. So pure seminoma in the specimens and initial equivocal node that's increased in size on a repeat scan 2 months after the initial scan.
2 months after the initial scan. So I would use chemotherapy.
In all three groups, or would you?
I would use chemotherapy in all three groups. If it increased in 2 months, yes.
And would you give different regimens to these men?
Yes, as I told you, in France, in any case we use EPs because we want to avoid bleomycin toxicity, even in patients who do not necessarily have contraindications or reasons to worry about bleomycin. But I would certainly avoid bleomycin in the 40-something-year-old who is a smoker and the elderly patient.
And so your preferred management now, and all things being equal, is a 4 EP protocol as the preferred initial.
Yes, without that meaning that 3 BEPS is not as correct. It is correct, but you're asking me, and I'm giving you my opinion, which is really the principal modality in France. We follow up to a disease. If it was going slowly, really slowly, progressing really slowly, then we would discuss a local modality. But you gave me a scenario where it is increasing very quickly. So, but let me just say that we would proceed by doing a biopsy. This is important. I didn't say that, but this is important. We wouldn't necessarily go for a 2B disease without giving biopsy, but we already have without having a biopsy, sorry, but we already have an indication of the kinetics based on what you gave me.
And if it was a relapsed surveillance, so they're 18 months, 2 years out, and they've got a 1.5 cm lymph node in the appropriate site, how would you approach?
Then I would, provided markers are negative, I would follow it up for a little bit, and then I would discuss surgery, because we need documentation in any case, and it's a small node.
And if it was seminoma, how would your treatment be the same as that initial?
What do you mean? That if I did, I just said that we would go for surgery if there was a single isolated node, to be certain that this is disease, and B, to avoid the burden of treating, with a full metastatic disease regimen, a small disease.
Yep. And you mentioned issue that radiotherapy and chemotherapy appear to be equally effective. Now, obviously, there are concerns with radiotherapy, but what is the patient profile that you think should receive that treatment given its oncological equivalence?
I said that in the systematic review they were equally effective, but I also said that for the 2B disease,
chemotherapy, 2A and 2B,
chemotherapy is preferable, and this was even more evident. It was 0. versus 0.4 for the relapse rates, when we selected for patients that were treated as per the standard of care, as per the 3 BEPS or the 30 to 36 grade for the 2B. So I would really, personally, I would very, very rarely use radiotherapy, for seminoma, early stage seminoma. I would either follow it up if it's 2A and marker negative, or if it progresses, I would give chemotherapy. But I would reserve the radiotherapy for relapse, especially relapse radiotherapy or surgery, depending.
So what patients would you give primary radiotherapy for?
The ones who don't want at all chemotherapy, or who have contraindications to it, like elderly, frail, etc., who cannot use at all cisplatin, which exists, and the ones who are, and I would certainly restrict it to not very high volume 2B, or certainly not 2C.
Okay. All right. Well, thank you very much.
But this is a very personal, biased opinion. We said what the guidelines say.
It is, and we thought we'd sorted out seminoma, and it's becoming more and more complex, isn't it?
It is. Thank you.
All right. Well, thank you, Anna. Next, I'd like to invite Professor Axel Heidenreich, who's from Cologne, and he'll address thromboprophylaxis and risk factors for thromboembolic events. And this is a topic that's recently entered our guidelines. So, Axel, could you take on this topic?
Yes, I hope that you can see my slides so far. And as you indicated, my topic would be thromboprophylaxis and risk factors for thromboembolic events in patients with testicular cancer. So I don't have any conflicts of interest. And this is the agenda I would like to go through. First, just risk factors for any type of venous thromboembolic events in cancer patients. Then I would like to refer to those risk factors of venous and arterial thromboembolic events in patients with testicular cancer. And then I will present some of the studies which have been performed so far. And I will conclude with the use of thromboprophylaxis to maybe reduce the risk of venous thrombotic events. And I will conclude with the recommendation of our guidelines. So let me start with risk factors for chemotherapy-associated thrombosis. And this is basically the major publication which has been produced about 15 years ago by Corona et al. You can see those various different risk factors which were used to predict the presence of or the development of venous thromboembolism in patients with different types of cancer. And these predictors have been at least validated in a cohort of more than 1,300 patients in both cohorts. So the initial cohort and the validation cohort, the frequency of venous thrombotic events was in the range of 2%. And if you use this type of point of scoring system, then this Corona score is able to predict the low, the intermediate, and the high risk category for the development of venous thromboembolic events. The only drawback is that less than 1% of all the patients who have been tested in this analysis were testis cancer patients. But this is basically the most clinically useful scoring system to have an idea about the high risk or the low risk to develop thromboembolic events during chemotherapy. Now, what are data with regard to testicular cancer? And this is a very large population-based study of more than 5,900 patients with testicular cancer. On the left side, you can see the various different cardiovascular events: venous thromboembolism, myocardial infarction, chronic heart disease, cerebrovascular accidents, or both. And what you can see is in patients who have received BAP chemotherapy, the most significant time interval during which such cardiovascular events develop are within the first year of the application of systemic chemotherapy. You can see it on these forest plots, which is located on the right-hand side of the table with regard to the PEB regimen. The most significant risk time to develop this type of cardiovascular events is during the first year of chemotherapy, either for venous thromboembolism or for myocardial infarction, and also for cerebrovascular events. So this time frame is where we have to monitor and to follow our patients more closely than the years after chemotherapy has been finished. This is just a study we have performed a couple of years ago, looking at venous thrombotic events in patients who have undergone systemic chemotherapy for testicular cancer at various stages. And the outcome was that 22% of our patients did develop a venous thrombosis or arterial thromboembolic complications. And we basically were not able to identify a single or let's say a couple of risk factors which were associated with the development of these venous or arterial thromboembolic events. What you can see is the majority of patients, 49 out of those 52 patients who developed some complication, did develop a venous thromboembolic event at various venous sites, and only 3 patients did develop an arterial thromboembolic event. When we looked at this patient cohort a little bit more in detail, we were not able to identify any patient-related risk factors for the development of a venous thrombosis. So neither age, nor body mass index, nor body surface area was a risk factor associated with the development of venous thrombosis. when we did look at some tumor-specific parameters, the only parameter which was associated with the risk of venous thrombosis was an elevated LDH, and it was an inadequate marker decline. We looked at multivariate analysis, and we did identify various risk factors on multivariate analysis, clinical stage 2C and 3, most probably due to the compression of the inferior vena cava. We did identify the elevation of LDH, febrile neutropenia during the first cycle of chemotherapy, and any patient who had a central venous line in place for the delivery of chemotherapy had a significantly elevated risk to develop venous thrombosis. And if you just look at the odds ratios, the central venous line was the most significant risk factor for patients to develop venous thrombosis. There are some other trials or some other retrospective studies who have looked at the risk to develop a venous thrombosis, and who also have performed a risk-benefit analysis of patients who were on prophylactic anticoagulation. And in this multi-institutional study, about 1,200 patients were analyzed. 1,120 patients did not receive any type of prophylactic anticoagulation. And if you look at the cumulative incidence of a venous thrombosis, again, the most significant risk factor was the central venous line in place. If you now would treat every single patient with a thromboprophylaxis, then the authors also have identified the number needed to treat those patients, and the number needed to treat would be in the range of 30 to 55 patients to prevent one thromboembolic event. There is another study published by the Svinatoka group, and they included a little bit more than 500 patients. And again, you can identify that about 20% or 11% of the patients did develop a thromboembolic event during chemotherapy. About 3% of the patients already started chemotherapy with a pre-existing thrombosis, most probably due to an advanced clinical stage, either to large 2B or 2C disease with compression of the inferior vena cava and the development of a thrombosis. But keep in mind, about 11% of the patients did develop a venous thromboembolic event during chemotherapy. When the authors were looking for risk factors which might have been associated with the development of an incident VTA, they also identified the only risk factor as central venous line. They were not able to either validate or to either prove that a high corona score of more than 3 was associated with a significantly increased risk to develop a thromboembolic event. And they also were not able to identify LDH, as we have done, to be associated with an increased risk to develop any type of venous thrombosis. There are some other patients. So if we just summarize these 4 different studies, you can see it's a different number of patients, population-based studies, multi-institutional data sets, or single center analysis. But the common finding is that the risk to develop a venous thromboembolic event is in the range of 10 to 20%. In most of the studies, it has been shown that the risk to develop such an VTE has a peak incidence during cycle 2 and 3. This is the time frame where we have to at least examine our patients very carefully. The most significant risk factor identified in all of those studies was the central venous line. So in our institution, for example, we usually never use a central venous line to deliver PEB or TIP or PI systemic chemotherapy. We only use this central access if the patient really has poor peripheral vein status. And in this situation, you just have to put in a central venous line. But in more than 90% of the patients, this type of chemotherapy can be delivered with a peripheral venous line. Prophylactic anticoagulation seems not to reduce the risk to develop a venous thromboembolic event. And right now, we are not quite sure why this type of prophylactic anticoagulation does not work in testicular cancer patients, and I will come to this in a minute. As I have said, there is also an increased risk to develop not only venous thromboembolic events, but also to develop arterial thromboembolic events. And this has been shown in the Svenotoka study, which I just referred to with regard to venous thrombosis. If you just have a look at the arterial embolism, a total of 2.5% of patients did develop this type of arterial embolism. Majority of patients did develop myocardial infarction, and a few of those patients did develop a peripheral occlusion of limb arteries, which resulted either in some type of surgery or even amputation of the lower limb. Similar data have been produced by our study, and this analysis has just been submitted. We evaluated 467 patients treated within a 3-year time frame, and 2% of our patients did develop some type of arterial cardiovascular event. The majority of the patients, as it was shown in the Svenotoka study, did develop myocardial infarction, and 1 patient each did develop an arterial occlusion of a lower limb artery or a cerebrovascular accident. All of those patients did have a typical thromboprophylactic medication, but as we know, it usually does not work on the arterial limb of our vascular system, so thromboprophylaxis was not effective to prevent arterial thromboembolic events. And if we just come to, let's say, the conclusion, are there any prospective randomized trials giving us some hint that maybe new types of thromboprophylaxis might be useful to reduce the risk of significant venous thromboembolism? Yes, there are 2 studies which have analyzed thromboprophylaxis in cancer patients with novel anticoagulating agents. So one study was a prospective randomized trial using apixaban versus placebo, and the other study was a prospective randomized trial using rivaroxaban in cancer patients with a high risk to develop venous thromboembolic events. And high risk was defined by a corona score of at least 3. And if you just look at the outcome of this study, both of the studies did demonstrate that there is a significant reduction in the development of thromboembolism if patients are subjected to this new type of thromboprophylaxis with either apixaban or with rivaroxaban. So the hazard ratio to reduce the risk of thromboembolism was in the range of 0.4, so an about 60% reduction to develop this significant side effect during chemotherapy. The only drawback for our testicular cancer patients is that less than 1% of the patients were testis cancer patients, and the majority of those patients did have some other solid cancer types. So what do the guidelines recommend nowadays with regard to the use or to the non-use of thromboprophylaxis? We have on one hand the recently updated ASCO clinical practice guidelines, and those guidelines tell you using the corona score, clinicians may offer thromboprophylaxis either with one of the new anticoagulative agents or with low molecular weight heparin in selected high-risk outpatients with cancer, and selected high-risk cancer patients were those who had at least a corona score of 3. With regard to testicular cancer, the EAU guideline does not give you a general recommendation because, as I have alluded to, we don't have prospective randomized trials in testicular cancer. However, we know that testis cancer patients are at high risk to develop venous thromboembolic events. As I said, the risk is somewhere between 11 and 20%. However, we still need to identify those risk factors which might be associated with the development of thrombosis in large population-based studies. But we also know that testis cancer patients, except for the ones who have choriocarcinoma, have a very low risk of bleeding. So at least we know once we put every patient with a high corona score on thromboprophylaxis, we will not harm the patient. We also have seen that thromboprophylaxis does not necessarily reduce the risk of venous thrombosis. But if you think that a patient might need thromboprophylaxis, for example, because of a high corona score, because of the necessity to put in a central venous line, you either should use low molecular weight heparin starting at the first day of chemotherapy and continuously delivering this type of prophylaxis treatment at least about 4 weeks after the last delivery of chemotherapy. And you also might use these novel anticoagulative agents, apixaban or rivaroxaban. Both of those agents have been tested in prospective randomized trials. However, with the only drawback I alluded to, less than 1% of the study population was testicular cancer. So with regard to thromboprophylaxis, we don't have these prospective randomized trial. The situation is still a little bit unclear. What do we do in our clinic? We put every single patient on a thromboprophylaxis once he receives chemotherapy, independent on the type of chemotherapy, except those patients who have, for example, carboplatin monotherapy. They don't receive thromboprophylaxis, but all patients who receive PEB, PI, or TIP do receive thromboprophylaxis. That's all from my side. So thank you very much for your attention, and I'm definitely open for any type of questions you might have.
Thanks, Axel. Can I ask just in general terms, with patients who have a large retroperitoneal mass causing some distortion of the cava, but there's no evidence of caval obstruction, what would you recommend in that situation, given that it sounds that we don't know or haven't proven that it's a benefit? Mm-hmm. So how would you manage that particular patient? Someone's got a 9-10 centimeter mass, into our cable, placing it.
So we will put those patients on thromboprophylaxis based on the retrospective series of our institution I just demonstrated, where we did identify clinical stage 2C, or which would resemble this 10 centimeter mass, as a risk factor for the development of venous thrombosis, even in multivariate analysis. So this would be a patient in whom we definitely would start thromboprophylactic treatment. And dependent on the renal function, we either would use low molecular heparin if there would be some impairment of renal function, or we would use the novel anticoagulative agents in patients who have just a normal renal function.
What about the patient who had a HCG of, let's say, 7,500? What would you do? Anything different in that sort of group?
Yeah, and this setting is so, because, I mean, if you have this very high HCG, you might think that this patient have at least a significant choriocarcinoma component in his metastatic deposits. And we know that all these choriocarcinoma deposits have a high risk of bleeding even without anticoagulative treatment. So I would be very careful in this situation, especially if the patient has lung metastases or brain metastases. We would not use thromboprophylaxis. If the patient only has retroperitoneal disease and there would be some type of obstruction of the IVC, we still would give thromboprophylactic treatment, but as I said, not in the situation of visceral metastases.
Okay, and what about in the situation where someone's developed, say, iliofemoral thrombosis? What are your thoughts in terms of therapeutic anticoagulation and things like cable filters? And again, coming from a surgical perspective, someone who's likely to need surgery after completion of chemotherapy, how would you manage that scenario?
Yeah, so we never, we have used this type of vena cava filters many years ago, but we have omitted to use it because it will complicate surgery afterwards extremely. It will not, it will prevent pulmonary embolism, but it will not prevent the development of thrombosis. And many of those patients who have a vena cava filter, they still develop thrombosis, but then just below the filter. And then it will definitely make surgery more difficult. And it might even end up to the situation that you have to resect those thrombus, that you have to take out the filter, which, as I said, will complicate surgery significantly. So I don't see any indication for a vena cava filter to prevent pulmonary embolism.
So you'd fully anticoagulate that patient?
Yes, I would fully anticoagulate this patient, definitely. But as I said, I would not use the filter, but full anticoagulation, yes, definitely. Mm-hmm.
And do you think that these patients, because of their disease, have a procoagulant state, or do you think the chemotherapy may induce some sort of procoagulant state?
At least, yeah, I think for those patients who develop these arterial problems, it's definitely due to chemotherapy, and most probably due to cisplatin. We have a couple of published studies which have looked at the, let's say, the thickening of the coronary vessels prior to chemotherapy and during chemotherapy, and they did identify a significant increase in the wall thickness or thickness of the coronary arteries, which will then result in ischemia. So I guess it's a combination, some type of coronary heart disease, then chemotherapy, which will induce the problem. With regard to the venous limb of our vascular system, I'm not quite sure. I guess it's a combination of a procoagulant status, because we also have a couple of studies demonstrating that D-dimers and fibrinogen is significantly increased in patients with testicular cancer. So this might give a cause for the development of thromboembolism, but we still have too few data to prove this, let's say, pathophysiological event.
And with peripheral lines, I guess we use PICC lines for those that can't always get it. Are they prone to the same issues as a internal jugular line and so on? It doesn't matter whether it's peripherally sited or whether it's centrally inserted.
Yes, so it doesn't make any difference. So that's why we, for example, don't use the PICC lines for systemic chemotherapy. We use it for all other types of, let's say, repetitive or continuous intravenous application, like long-term antibiotic treatment, parenteral nutrition, things like this. But we don't use it for patients who receive chemotherapy. So testis cancer, bladder cancer, we don't use the PICC lines. We just use a peripheral line, and we didn't see any increase in complications, like, for example, a paravisation or things like this. You just have to make sure that your peripheral line is, let's say, large enough in its diameter not to cause any venous complications.
And I guess the other final point is cisplatin seems to be the agents implicated. Does carboplatin have the same implications? Does anyone know about that?
No, I don't know about that, because in most we haven't looked at it. We did perform an old study with 3 or 4 cycles carboplatin in stage 2A and stage 2B seminomas, but I don't recall the risk of venous thrombosis in those patients. It was a cohort of 200 patients, but I don't recall if there was a significantly increased frequency of thromboembolism. And I don't know any study comparing cisplatin or carboplatin, though I can't answer the question.
And I guess just
do you want the input of the medical oncologist on that?
Yes, Anna, please.
As Zach said, we don't have information on testicular cancer, and furthermore, carboplatin doesn't really work, so we can't get more data. We do not replace carboplatin with cisplatin, but we have information from lung cancer patients. So when they compared carboplatin with cisplatin, the risk was the same, but there tends to be more arterial thrombosis with carboplatin compared to cisplatin. But the overall risk is the same.
Mm-hmm.
And Axel, just with the issue of the patient who's experienced thrombosis, what do you think, how long should the patient continue with anticoagulation subsequently? Should it be for a 3-month course or a more protracted course? As in, does their risk diminish over time, or should they be fully anticoagulated for a much longer period of time? You showed that some things dropped off after the first year. So how long would you anticoagulate someone who's had a thrombotic event?
Yeah, so that's always the question, because we don't have really good data from like prospective or even just some prospective, must not be prospective randomized studies, just prospective studies. So what we usually do is we put patient on anticoagulation for about 4 to 6 weeks after the last, so after day 21 of the last cycle. So they are just put on anticoagulation for 6 weeks, but this is more, I know, a gut feeling. This is no scientifically proven. And so the idea right now is to just get some of the large centers together to evaluate patients who are on thromboprophylaxis and to evaluate these different schemes of a continuous thromboprophylaxis to have some idea what we really should recommend to our patients.
Okay. Well, thank you very much. It's as we know, we discussed a lot surgically whether you should or shouldn't, but it's interesting. I think the procoagulant issue is the one that probably needs to be explored to try and identify those that have some sort of factor something response to the introduction of cisplatin, because it clearly does heighten their risk very, very significantly and provide significant morbidity. So thank you very much. We'll move on now to Professor Boormans from Rotterdam, who will discuss staging and prognostic symptom scores, and also what their potential utility may be in terms of clinical practice.
Yes, thank you very much, David. I'll start sharing my screen. Hopefully you can see my screen. My name is Joost Boormans, a urologist at the Erasmus Medical Center in Rotterdam, the Netherlands. And these are my disclosures. Well, I first will talk about the clinical stage 1 seminoma testis and on the work we've done with the guideline panel just lately. So what we know is that 70% of the patients with seminoma testis present with clinical stage 1 disease, and that the risk of relapse following orchiectomy varies between 4 and 30%. Well, adjuvant treatment strategies include surveillance, which is the recommended treatment, current recommended treatment, but also carboplatin and predominantly in the past retroperitoneal radiation. And these adjuvant strategies were predominantly based on prognostic factors, and the prognostic factors studied were the primary tumor size of less versus larger than 4 centimeters and the rated testis invasion. But these prognostic factors both have important limitations. First, I would like to start with the tumor size. The cutoff of 4 centimeters derives from a study dating back from 1993 in 148 patients. It was an old cohort, and the median tumor size of that cohort was 4 centimeters. And ever since then, it's been used as a cutoff to drive adjuvant treatment strategies. However, in current series, the median tumor size is smaller, varying between 2.5 and 3 centimeters. What about rated testis invasion? Well, the pathological reporting on RTI is not standardized, and what you see, there's a large variation in the reported prevalence in the series, varying between 15 and 67%. And also, there's an important difference maybe between paged width versus stromal invasion of the rated testis. So because of these limitations, the guideline panel stated that there's insufficient evidence to justify the use of either risk factor in clinical decision-making on adjuvant treatment in. So, well, apologies again. Then, so the background of clinical stage 1 seminoma testis is that the risk of relapse following orchiectomy is between 4 and 30%, and adjuvant strategies include surveillance, chemotherapy, or retroperitoneal radiation. And adjuvant strategies were predominantly based on prognostic factors, primary tumor size with a cutoff of 4 centimeters and rated testis invasion. So the limitations of these prognostic factors, first, tumor size. It was based on a series by Ward et al. In 1993 published with a median size of 4 centimeters. And ever since then, the median tumor size has been used as the cutoff to drive adjuvant treatment strategies. However, current series show that the median tumor size varies between 2.5 and 3 centimeters. In addition, the reporting on rated testis invasion is not standardized. There's a large variation in reported prevalence in series between 15 and 67%. And also the difference between paged width rated testis invasion versus stromal rated testis invasion has not been taken into account. So the guideline panel stated that there's insufficient evidence to justify the use of either risk factors in clinical decision-making on adjuvant treatment in seminoma 1. So with the guideline panel, we tried to identify additional risk factors associated with relapse in clinical stage 1 disease. We compiled a retrospective cohort of more than 1,000 patients from 9 centers, and the inclusion criteria of the cohort were patients had to have unilateral primary clinical stage 1 seminal metastasis undergoing active surveillance, so no adjuvant treatment, active adjuvant treatment. They had to have normal serum tumor marker levels post-orchiectomy, had to have a minimal follow-up of 12 months for patients without a relapse, and the presence of RTI should be known. The patients had to be followed according at intervals according to institutional clinical guidelines, and the primary endpoint of the study was the time to relapse as assessed by imaging and/or elevated markers. The probability of relapse was estimated by the Kaplan-Meier methods, and we built a multivariable Cox proportional hazard model was built to identify prognostic factors. Assuming a maximum of 6 variables included in the model, we had to observe 15 relapses per variable, needing 90 relapses, which translated into a minimum of 600 patients for the cohort and a maximum of 1,200 patients for the cohort with an incidence of relapse of some 7.5%. Next slide, please. So the results of the study, the baseline characteristics are depicted in the table. The median age of the cohort of 36 years, and the median tumor size was 3.2 centimeters, so less than 4 centimeters. Rated testis invasion was observed in almost 1 in 3 patients, and lymphovascular invasion was present 12%. The median follow-up of the cohort was almost 8 years, and 14.7 patients relapsed, either assessed by imaging or imaging plus markers. And almost all relapses occurred in the retroperitoneal nodes. 45% of the relapses occurred in the first year, and the median time to relapse was 1.1 year. Next slide, please. So we built this prognostic model, univariate and multivariate analysis, and finally, in the final model, we included primary tumor size, rated testis invasion, and lymphovascular invasion. And primary tumor size was stratified into less than 2 centimeters, between 2 and 5 centimeters, and larger than 5 centimeters. Multifocality, GCINS, serum tumor marker levels, and age were not prognostic. Next slide, please. So we then built risk groups based on these parameters I just mentioned to you. And we looked at the probability of relapse at 1 year and 5 years. And the cohort of 1,000 patients was stratified into a low-risk group with small tumors, no rated testis invasion, no lymphovascular invasion, or either one of these, but not both. It's depicted as low risk. More than half of the patients were low risk, and they had a probability of relapse at 1 year of 4%, 5 years at 8%. Then there was an intermediate risk group, 41.3%, with a relapse rate of 10% at 1 year and 20% at 5 years. And a very small high-risk subgroup having tumors of more than 5 centimeters, having rated testis invasion present and lymphovascular invasion present, with a probability of relapse at 1 year of 30% and at 5 years of 44%. So 3 risk groups, low risk, intermediate, and high risk, but the high risk group was a very small group of 2.3%, having tumors larger than 5 centimeters and rated testis invasion and lymphovascular invasion. Next slide, please. So these are the curves of the 5-year cumulative probability of relapse. The red line depicting 5 years of follow-up, and then you see the numbers, very low of the low risk group, 563 patients, low, intermediate should it be 412 patients, and then high risk. And again, the high risk group is only 2.3% of the population, having a relapse rate of almost 50% at 5 years. Next slide, please. Then we tried to validate these findings in a separate cohort. It was smaller, 285 patients from Switzerland and Austria with the same inclusion criteria. However, the median follow-up was shorter, so 3 years versus 7.7 years of our cohort. and the relapse rate was 12.2% in this cohort, which is almost more or less the same as the 14.7 we found. And again, the low risk and intermediate risk groups were validated in this cohort. However, we had only 8 patients with high-risk disease, so large tumors with RTI and LVI present. Next slide, please. So we propose a new prognostic model for clinical stage 1 seminoma testis. However, the study has some limitations. It's a retrospective compiled cohort. We didn't have central pathology review. The majority of the patients were included at large centers with GU pathologists, but there was no central pathology review, and so we cannot stratify between page width versus stromal-related testis invasion in this cohort. There were differences in upper limits of the HCG across centers, and obviously the validation cohort had a shorter follow-up and a smaller sample size. Next slide, please. So we conclude that the risk of relapse in all comers in clinical stage 1 seminoma testis patients is limited. In our cohort, less than 15%. And obviously we know that the outcomes of patients is excellent with a 99% cancer-specific survival. The new risk stratification performed better than the conventional model, which is based on tumor size cutoff of 4 centimeters in RTI. So we now have tumor size less than 2 to 5 centimeters and larger than 5 centimeters. And lymphovascular invasion has been identified as an additional risk factors. We have a very small subset of patients with a high risk of relapse of 44% at 5 years. And this may warrant discussion on adjuvant therapy in this high-risk subset, but it justifies the surveillance strategy as preferred strategy in low risk and intermediate risk. Next slide. So I switch gear to the metastatic setting. Anna just touched upon it already, but the prognostic classification used for metastatic seminoma and non-seminoma patients was based on very old cohorts dating back to the 70s and 80s and rather small cohorts. And these cohorts have been updated for seminoma from 660 to almost 2,500 patients. And for the metastatic cohort from more than 5,000 to almost 10,000 patients. These data have been published 2 years ago, and what we see is that the risk stratification, good and intermediate for seminoma versus good, intermediate, and poor, was retained, but survival probabilities almost all were better. So next slide, please. So these are the curves for seminoma. I have to thank Professor Heidenreich for sharing these slides with me. And what you see is that the progression-free survival and overall survival for both good prognosis patients and intermediate prognosis patients improved substantially. This is probably due to the introduction of cisplatin chemotherapy. Next slide, please. LDH above 2.5, the upper limit, was identified as an additional risk factor in the discovery cohort. Next slide, please. And for non-seminoma, progression-free survival and overall survival were also better for the good and intermediate risk group, and only 5-year PFS. In the poor risk group was only 5-year PFS and 5-year OS better. Next slide. So these new prognostic risk classification improved the granularity of the model, including now with LDH above 2.5 times the upper limit. Next slide, please. And these findings were translated into a nomogram. On the left side, A is the 3-year PFS without non-pulmonary visceral metastasis. On the right, panel B, the 3-year progression-free survival with non-pulmonary visceral metastasis. So to conclude on the metastatic prognostic markers, there has been an improved granularity predominantly based on more recent cohort with larger patient sample size. Next slide, please. My apologies for the technical issues. Hope there's still some participants left, but I hope I made clear that we have now an improved prognostic model for clinical stage 1 seminoma metastasis, as well as an improved model for the metastatic setting of both seminoma metastasis and non-seminoma metastasis. Thank you.
Thank you, Joost. Very interesting, the fact that you were able to identify sort of 3 stratifications with seminoma into what seems to be a very high risk group, or we'd probably call a conventional intermediate risk and low risk. What are the implications of that high risk group, and where should we go from here with those? I know they're only a small subset, but...
Yeah, so if you would translate those findings to non-seminoma, then we know that clinical stage 1 non-seminoma metastasis patients with lymphovascular invasion have a risk of relapse around 50%, and we advocate adjuvant BAP in those patients. You might consider to advocate adjuvant treatment in this very small subset of seminoma patients. On the other hand, still more than 50% is cured by orchiectomy alone. So I think this is important to discuss with your patient, and if he is willing and able to adhere to strict follow-up regimen, then I would suggest that with the de-escalation strategy we would adhere, that surveillance is still to be preferred. Mm-hmm. However, in some countries with large distances, for instance, to medical care, then you could you might consider to recommend adjuvant treatment. Yeah. And
and age wasn't a risk factor in any of these analyses. I know you covered the data, but I missed that.
Yeah, so only we included in the model, but it didn't turn out to be prognostic, no.
And so with the new systemic disease risk stratification, where do you think that will influence things in terms of will that allow us to de-escalate some patients, perhaps use some of the more modest protocols that Anna described? I'm interested in her comments as well on that. So what do you think that would be? Is there sufficient confidence in those sort of reclassifications?
In the classification itself, I think yes, definitely. And in the de-escalation strategies, well, I think it's, for us clinicians, one of the most important and interesting issues that have to work on, because of the long follow-up we now have. We know that the risk of dying of other diseases from testis cancer survivors is much higher than the general population. So we know that exposing them to cisplatin chemotherapy later translate into different problems, and also from radiation. Obviously, we know the increased risk of second malignancy. So,
and I guess the other question with seminoma, there is a lot of interest in sort of de-escalation of our stage 2 management, so that people range from sort of 3 BEPs, 4 EPs, and even more modest regimens, and more recently surgical intervention. Do you think the parameters you've defined apply to the risk of relapse, but also to more aggressive disease when they do relapse?
Yeah, interesting question. Well, we know that the chances of cure by salvage chemotherapy for patients who relapse is very high, so more than 99%. So the only thing is that we know from adjuvant carboplatin patients who have a relapse despite one course of adjuvant carboplatin, they seem to do a little bit worse than with the primary relapses. Yeah.
Yes, they're an interesting group. They tend to relapse later and have some element of chemo resistance, whether that's the reason they've relapsed or whether they've selected out platinum resistant clones as a consequence of that low early exposure is a point of conjecture. So Anna, from an oncologist, how do you see this reclassification influencing your practice?
Right. So first of all, as Justus said, the update is not reclassification. The update, or this classification has showed us that it is still very much valid, which is very important to keep in mind.
So it's reinforcing current practice rather than changing it.
Reinforcing current practice, and this is important for seminoma because, as I think you said, it was very limited, the number of initial seminomas. There were like 600 something, not a very important number of seminomas in the initial classification, and now we have more. And that's good to know that, you know, that this classification that we have been using in order to direct practice, but also to, you know, that has helped us improve the survivals and the survival rates and outcomes is still valid. It has given us, you know, some fine-tuning, and in my opinion, it is very interesting, the fine-tuning that provided us in regard with the LDH in seminoma, which essentially, and again, it is debatable, it reflects to me the disease size, essentially, within that. It has not as yet changed practice, but it is really, really interesting in my opinion. As to what you asked about, do these factors that we use in the first line for risk classification, for prognosis classification, are they applicable to the second line? And it is included in our guideline. We have the criteria that Anya Lorge has described for the relapse setting. And it has to do, they have to do with how well the quality of the prior response, the progression-free interval, of course, the markers, and of course, where this metastatic disease is. So it is a little bit more complex on this classification for the first line for the treatment-naive patients, but, and histology also, you know, all the previous, you know, essentially, factors do apply, but the quality of response and the rapidity of relapse also plays a role here.
And just on the de-escalation topic, with surveillance, can we de-escalate imaging?
Oh, yes, you
low risk.
Is that an introduction to the TRIS trial? It is.
I was about to say the TRIS trial have already undergone some reduction, but there may be minimalist need for patients. I mean, they're still doing the markers all the time, and so they do come up to hospital for tests, but if someone is truly low risk, that they could have a very sort of soft touch to their surveillance. I mean, they have to be followed, but perhaps not nearly with the intensity that we do at the moment.
Yeah, I agree, and we need more de-escalation studies on the imaging. One caveat that the patients for whom the markers were non-informative initially, maybe these are the patients where we would need to rely on imaging. Certainly not more than we do right now, but you know, these would be the patients and the teratoma patients, for example, the patients with significant teratoma component. But the patients for whom markers were really informative preoperatively, and they, you know, they normalize afterwards as they ought to do in a stage 1. These are certainly patients that I would want to see imaging de-escalated.
Yes, the numbers in the low risk that relapse is probably quite small. But was there a correlation between the volume of disease at point of relapse, as in biological aggression, in those high risk compared to those, the few numbers, the low risk that did relapse?
Yeah, no, we didn't find any such correlation. No.
So it was independent of the status. That wasn't predictive of. That's interesting.
But did we look into it for seminoma?
Yeah.
We did look into it.
Within this cohort, yes.
Yeah.
Well, it's a very interesting concept, and I think there's more work coming out. So I think this risk stratification may be something we'll be looking at some changes in the next lot of guidelines. So we've just come to the end of our presentations. I'd like to thank each of my panelists for their work, not just here, but also on the guidelines. It's a big team effort, and so thank you for that, and thank you for the presentation tonight. So I'd just like to thank all the participants, and also Fitri for organising this meeting tonight. So thanks for coming along, thanks for contributing, and have a good night.
Bye-bye.
Thank you very much. Goodbye.